Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years.
Hello and welcome. Today's presentation, Signs and Symptoms of Sepsis, is presented by emergency medicine specialist. Our first presenter is Dr. Shekar Srinivas. Dr. Srinivas is an emergency department attending physician at Washington Hospital. Without further ado, please welcome Dr. Shekar Srinivas.
Good afternoon and welcome to today's presentation. I'd like to thank Washington Hospital for allowing us a platform to give this talk, and it's great that we're doing it in the month of September, which is Sepsis Awareness Month. So today's talk with Dr. Htet is sepsis, why it is important, complicated, and evolving. So we're going to start off with a case vignette. You're not feeling very well at home, you have some fever, malaise, feeling tired, some abdominal cramps, some crampy pain, kind of diffuse. Notice changes in your urinary frequency, and you're just not feeling like yourself. And you can't eat and drink like you normally do. And then it's going on for about a week. Today, you noticed a high fever. You're feeling nauseated. You have some dry heaving. Just feeling horrible. And again, just not doing the kinds of things that you are normally accustomed to doing, and you're feeling dizzy even at rest. So you're going to come into the ER because it's after hours at 6 p.m. You can't get a hold of your primary care doctor, and you come to Washington Hospital Emergency Department. And I'd just like to take a moment to thank all the ER personnel. We've had an amazing group of people working at Washington Hospital in the ER, the physicians, the nurses, the EKG techs, the ortho techs, the registration clerks, et cetera, and EMS as well in the community for providing all the care that we have in these times. But on arrival, back to the vignette, these are your vital signs. Temperature is 102.4, which is high. Blood pressure is 88/50, which is low. Heart rate's 127, that's fast. It should be between 60 and 100. Your breathing rate is fast. It's 24. It should be between 12 and 20. So these are all abnormal. And you can check pretty much all of these at home, actually. So if you have a thermometer, you can check your temperature. It won't be as accurate as, say, a rectal temperature, but it would be pretty accurate if you do an oral temperature. Blood pressure cuff, if that's available to you, you could check your BP. Heart rate, you can check your radial pulse right here. It should be between 60 and 100. You can count it on a clock over the course of 1 minute. If it's higher than that, which is very, very commonly seen in sepsis, it usually indicates something's going on with your body. If it's low, something may also be happening below 60. Breathing rate as well, you could put your hand on your chest and just count how many times you're breathing. 24 is above the upper limit normal of 20. So we obtained some laboratory tests on this patient. White blood cell count of 18,500. Kidney function tests are abnormal. That's 47 BUN and a creatinine of 2.4. To go back to the white blood cell count, it should be upper limit is about 10,000 roughly. So that is high. The kidney function tests are about double or a little bit more than that of normal. Lactate is 4.6. It should be below 2, so that's also elevated, and that's a marker of metabolism. That's helpful for providers to distinguish the mortality rate. So the higher that is, the higher the mortality rate. And it can also track patients. So if they have a high lactate and we do interventions and we recheck it and it comes down significantly, we know we're on the right track. Also, a urinalysis is obtained that shows positive for white blood cells, nitrites, and leukestrase, which is an enzyme secreted from the white blood cells. And so it looks like an infected urine as the source. Chest x-ray is obtained and it's negative. It looks clear. So we're going to give interventions to treat the urine infection. How can that happen? Well, you can get colonized with E. coli, which is the most common bug, bacteria that can cause urinary tract infection. It can penetrate through the uroepithelial cells into the bladder, all the way up the ureter on both sides, or one side typically, up all the way to the kidney, and that can cause a pyelonephritis, sometimes even an abscess next to that, and sometimes that can lead to acute kidney injury as well. So in the ER, we're doing all these things, diagnostic tests, we're running through differential diagnoses for patients that come in with hypotension, giving supplemental oxygen as needed, starting IV fluids in large bore IVs, giving antibiotics preferably early, continuously monitoring the patients, and potentially doing some of these other interventions listed below, like intubation to protect one's airway, central venous catheter, which is a large bore catheter, bigger than your typical peripheral lines, to administer blood pressure medications, blood pressure sustaining medications, vasopressors, arterial line to have a more invasive way of measuring your blood pressure in real time, incision and drainage of an abscess, let's say, that sometimes we need patients to take a break from what is actually going on. A lot of their blood flow, 25%, 30%, can go directly to the lungs to deal with their increased respiratory rate, and it takes away from other parts of the body, so from the brain, for example, from the kidneys, and it starts perfusing the lungs. So intubation, one of the reasons is also to give a break to the patients and give the patients some time to heal, and our interventions to start kicking in and working. So that patient got transferred to the ICU and hopefully is in the right direction, moving in the right direction. So to take a step back here, just briefly, the history of sepsis. Hippocrates, 4th century BC, he coined the term sepsi, which is to make rotten. Semmelweis was an Australian OBGYN who essentially pioneered hand washing. Noticed some students were in the cases and there were some bad outcomes, high mortality rate, and he implemented a hand washing regimen, and it turned everything around and led to better outcomes. Pasteur is a French chemist that discovered bacteria, and Fleming's a Scottish physician that discovered penicillin. So it's a pretty costly condition, fast forwarding throughout the years. In the US, this is pretty recent data in the last couple of years. About 1.5 million cases and hospitalizations per year. 1 out of 3 deaths in the hospital due to sepsis. About 250,000, just over that, deaths per year. It's the 3rd leading cause of death behind cardiovascular disease and cancer. The cost is about $24 billion per year. And it's the most expensive condition in the hospital, essentially. It has a pretty high mortality rate, which we'll touch on later, that kills more individuals than prostate cancer, breast cancer, and HIV/AIDS combined. So it's pretty significant burden on the system. It's also number 1 in hospital readmissions. Some more statistics to run through really briefly. Greater than 2/3 of cases are diagnosed in the ER. 90% originate in the community. Remainder of them are diagnosed after admission. And at any given moment, about a quarter or a little bit over that, patients in the ICU have septic shock. And about 60% or so of the community is aware of sepsis, the term, and what it means. So there's still some room for improvement there. In terms of economic burden in comparison to heart attack, the darker bars there, so the x-axis shows years from left to right, and on the left side it goes, on the y-axis it shows hospitalizations, and on the right side it shows dollars spent in billions. And you can see, the dark bars, sepsis, and the white bars are acute myocardial infarction or heart attack. And as the years are going on, there's a bigger discrepancy, as well as in hospitalization rate. So the line that's going up is for sepsis, the line that's going down and the lower line is for AMI. So there's, over the years, it's higher cost and also higher amount of hospitalizations. A little bit of a dated slide, but this is the one that we have that's most recent. It's overall deaths that have, in the trend, that shows that it's actually improving from 45% roughly to 25%. And this is taken on the left side in the early 90s or so, 90 to 92. You can see it hovering around 40% or just above that, down to upper 20s about a decade ago. So there's also a mortality difference depending on which age you come into the hospital at. So if you're higher in age, if you're older, 70s, 80s, 6th, 7th, 8th decade of life, you can see the mortality rate goes up pretty significantly. There's a little bit of a difference between male and female. Females have a little bit higher preponderance in the 2nd and 3rd decade of life, and 4th, and then beyond that, males have a higher preponderance. But generally speaking, as you go up in decades, the mortality rate goes up pretty significantly. So the geriatric population has a 9 times higher mortality rate due to increased comorbidities at large. And once patients have sepsis and they recover, hopefully, there's also post-sepsis syndrome to talk about, where there's potentially cognitive disturbances, emotional disturbances of anxiety and depression, loss of memory, and some functional and physical disturbances that can linger on for months, like exercise intolerance and muscle wasting. So this slide and the next couple of slides is highlighting one of the treatments that we have that is probably the most important treatment, and that is antibiotics. So timing is everything. Mortality rate increases 8% every hour that treatment is delayed. And it was thought that some of these things are preventable. Some of these cases are preventable. There was a study in 2019, it was a JAMA study that looked at this, and it looked at some tertiary care centers, and there's about 600 patients in total. And long story short, it's about 13% of cases that are deemed somewhat preventable, moderately preventable, or possibly preventable. So the vast majority were deemed not very preventable when a patient comes in and has sepsis. Now, there are things that we can do before that happens that we'll talk about in a bit. But once you present and it looks like you're headed down that road, we're limited with what we can do. But antibiotics is definitely a major factor in helping to treat patients early on. So early administration of antibiotics, this is a slide taken from the American Journal of Respiratory and Critical Care Medicine 2017, a study by Liu and colleagues. And basically, don't want to go into details here, but the long story short is the greatest benefit is seen when antibiotics are given within the first hour and in those with septic shock. And they basically found a similar finding as the prior slide, where early antibiotic administration was associated with a 9% increase in the odds of mortality in patients with sepsis. So it's a similar idea with this slide, only it shows patient survival rate and starts off in the 80s on arrival, and it dips down to about 50% at the 4-hour mark, and it just completely keeps going down linearly like that as the hours accumulate. There are some more recent studies that are debating how early is early. So you can give antibiotics between 0 and 1 hours. You can give it between 1 and 3. So the immediate group and the early group, is there really a difference? And I think there's some more studies that need to be done to delineate that. But at the end, you won't find any studies that would recommend delay in antibiotics. So they're very important, and we try to get patients broad-spectrum antibiotics very early. So to change gears here for a sec, high-profile cases, Paul Allen, he had non-Hodgkin's lymphoma, and he died of septic shock, secondary to being so immunocompromised. Cellulitis, Rusty Saab was a retired baseball player. Johnny Depp's daughter had E. coli. and recovered from that. Disc jockey Casey Kasem, he died from an infected wound. Mother Teresa died from an infected pacemaker. Jim Henson, Leslie Nielsen, Bernie Mac, George Michael, they all died of pneumonia. Pope John Paul II died from a UTI. So these are all different kinds of infections one can have that can lead to sepsis. And this graphic is from the Global Sepsis Alliance, and it shows some of the most common sources of sepsis. You have meningitis, cerebrospinal fluid infection, skin and soft tissue infections, possibly a catheter-related infection. The line is pointing towards the arm, so there could be, a PICC line there. Potentially that could be treating another infection. Urinary tract infection, pneumonia, bloodstream infection in those usually that are immunocompromised, and then intra-abdominal infections as well, like appendicitis, infectious diarrhea, gallbladder infection, etc. So this is another schematic that shows a similar kind of data. Lung infections are in red, and it's the biggest part of the pie because it's the highest in percentage. It's roughly 30%, 30 to 35%. Urinary tract infections, about 20 to 25% in orange. And then both skin and soft tissue infections in green and abdominal infections in yellow are anywhere from 10 to 12% of infections. And all of the other slew of different kinds of infections are about 10%, and that's in the light green. So pneumonia, for example, you can see the x-ray on the left. It looks like there may be some fluid there in the initial x-ray, but as it's evolving, it's getting worse, and it looks like it's developing into ARDS, some significant pus that you can see in both lung fields bilaterally. On the right side is a diagram that shows the alveolar interface and basically where gas exchange occurs at the capillary level. And in sepsis, when someone's pretty far along, that interface can get plugged up pretty significantly with inflammatory markers, and it can make breathing and gas exchange that happens at that microscopic level very, very difficult. X-ray example of a pneumonia in the right upper lobe, which you can see in the right lung field, which is on the left side of the screen. You can see an opacity there on the left. This is a picture of a cellulitis. And so as we were saying before, it's 10 to 12% or so of total sepsis cases. Looks like it's a pretty red erythematous, likely tender area of the leg. And bacterial growth, it's super rapid. If you take E. coli and put it on a plate, you can actually wait a day or so and you can see the bacteria growing there, which is what the plate shows on the bottom right. But compared to human beings, it's incredibly rapid. Essentially one bacteria dividing at its normal rate can give rise to a colony of millions in a few hours. This is a video that shows this blob that is, I don't know if it's comforting to say that we're reliant on some of these blobs in our body, but we are. These white blood cells that are going around, you can see it chasing this bacteria and engulfing it pretty much so that it can break it down and present it to some of the other cells and create this cascade so that your body can really ramp up and start working to fight off the infection. But your body relies pretty heavily on white blood cells to destroy bugs, and it's just an incredibly sophisticated machine. Essentially it constantly engages with the outside world, and it takes in some good elements and it tries to destroy some harmful elements. So who's at risk for sepsis? People at extremes of age, as we touched on earlier, men more so than women statistically, certain minority populations, patients with chronic diseases like COPD, CHF, heart attack history, cirrhosis, and hepatitis, where a lot of your proteins are being made in the liver. So one of those is your antibodies. So patients with hepatitis and cirrhosis are also on this list. Also patients with HIV or on steroids, say for COPD or certain autoimmune diseases, on immunomodulators, and diabetes I think is the most common. Here it's pretty important to highlight that, to get appropriate diabetic care and take your medications as prescribed for diabetes. And also those with reduced functional capacity like dementia, stroke, older age, and neuromuscular diseases. So there's also the risk factor of invasive procedures. So patients that are coming in that need a pacemaker, a defibrillator, stents, implants of some sort, hip replacement, knee replacement, all of those things that are in your body to help with a certain condition that you may have that aren't supposed to be in your body, they can become infected at some point. So it may not be some of the heavy hitters in the diagram that we showed in the pie chart earlier. It may be something like an implant, possibly. So some providers have to be in tune with that, and I think it's helpful for patients to be aware that any of these invasive procedures with pacemaker, et cetera, implants, that can cause sepsis. In terms of prevention, hand washing is highlighted up here at the top pretty boldly. It's very important. It's the most important bit on this slide. 20 seconds, hopefully you can wash your hands, both sides, between the fingers, between the nails, underneath the nails, in both hands. Vaccinations, pneumococcal vaccination, get it if you qualify. Flu vaccination, please get it if you can. COVID vaccination, please get it if you can. Childhood vaccinations as well. If you're prescribed antibiotics for some reason, take them as directed. Don't take your aunt's, cousin's, brother's, doxycycline because they thought it was a good idea once or twice. Take antibiotics if you're prescribed them. Preferably, it can reduce the risk and the rate of ESBL and other kinds of infections in the future that are resistant to our normal antibiotics. If you have wounds, make sure you care for them appropriately. Go to the wound care nurse if you have one coming to visit you. Check on them frequently. People have phones. You can take pictures of them daily and track your progress that way. I think that's a very easy and practical way of doing it. Definitely ask questions to your providers if you have any, and they'll be more than happy to answer. And I think most importantly is be attentive to your symptoms and kind of be in tune with your body as much as possible and kind of know your limits and know what you're used to doing. And when things are awry or slightly off, start to ask why that might be. To touch back on the symptoms briefly, this is a list of vague symptoms: confusion or disorientation, fatigue, decreased appetite, chills and or shaking, nausea and vomiting, feverish, dizzy. Any one of these symptoms can be, and usually it's multiple, can be part of a patient's presentation, and they're not necessarily specific to sepsis. So it's important to get as much information as possible from family, friends, nursing home staff, et cetera, because we regularly in the ER see patients that are coming from, say, a nursing home or from home, and family is away for a bit, or the patient is demented, or has other comorbidities, say a stroke, and isn't verbal anymore, and their shift change, say, and it's in the evening time, and it's just difficult to get a lot of pieces of information. So we tend to cast a wide net to look for what could be going on. But I think the most important thing is to try to step up to provide information as best as possible for the vulnerable community that exists. This is a diagram showing you, just for clinician purposes, definitions and signs. So they're old definitions: SIRS, sepsis, severe sepsis, and septic shock. Severe sepsis is out of favor now in terms of the most recent recommendations. SIRS kind of goes through your temperature, breathing irregularities, heart rate irregularities, and white blood cell count abnormalities. If you have two of those plus a confirmed or suspected infection, then you're deemed to be septic. If you have that plus persistent signs of end organ dysfunction, like liver dysfunction, coagulation dysfunction, kidney dysfunction, then and you're hypotensive. One of them is also a lactate. That's another sign of end organ dysfunction in terms of perfusion. Then you're deemed to have septic shock, and you'll more than likely need the ICU. So it's basically your body's run amok and there are pro-inflammatory markers everywhere. Fluid can go into spaces that it shouldn't, and it results in this syndrome. Our newest definition is in 2016, and it says sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. So it's basically your body's response to an infection resulting in injury to its own tissues and organs. And septic shock is a subset of sepsis where profound circulatory, cellular, and metabolic abnormalities increase substantially the rate of mortality. So sepsis without shock is 10% mortality rate, just about in the last 5 years. Septic shock is about a 40% mortality rate, so it's significantly high. This is a busy slide that I just wanted to touch on to show that, so it's a SOFA score, a sequential organ failure assessment score, and that is a tool mostly used in the ICU to track organ dysfunction in patients with sepsis. There are other tools out there, depending on which country you are, in the UK or elsewhere, and depending on which state you are as well in the ER, various states in the US use different scoring systems. So we use SIRS, as was shown earlier. There's also a SOFA score here. There's also QSOFA, which boils it down to a respiratory rate, altered mental status, and a low blood pressure. So all these parameters, it's kind of evolving, and there's no perfect screening tool. That's kind of the point of the slide. Some of these can be cumbersome and difficult to deal with in the ER. So we're still trying to figure out what is the best universal way of tracking it and diagnosing it early and continually monitoring it. So this is a slide to track back to a complete history and the importance of a complete history. It's very important to know when your symptoms began, what symptoms exist, and the severity of your symptoms, your past medical and chronic illnesses, sick contacts at home or at work potentially, any recent travel, and then medications you're currently taking. I always tell patients to carry along with them a piece of paper with their medications written down. They can keep in their wallet. There might be some changes there. They can easily just make a new paper or cross it out and put in a new dosage or what have you, maybe date it, put in who the provider is that wrote it, maybe the dose, how many times you take it a day, and why you're taking it. And I think it's better for patient awareness, for family awareness, and also for the providers to know the most up-to-date information. So that would be ideal. But again, getting information from patients, family, friends, pharmacies, doctors' offices, nursing home staff, etc., all of the above is vital to get as much as possible to provide the care that's necessary. So diagnostic testing, this is a list of some tests that are performed in the ER. Different cell counts, lactic acid, which was touched on earlier, procalcitonin, to see if there's a potential bacterial infection, kidney function tests, liver function tests, urine tests, and cardiac function tests. If a patient presents with a stiff neck, let's say, headaches, neck pain, fever, we are concerned about meningitis and encephalitis. We may obtain lumbar puncture and get CSF cultures, cerebrospinal fluid cultures, body fluid cultures, catheter tips. If you have that PICC line in for 2 months, let's say, that treated an infection before but never got it taken out for whatever reason, and a patient comes in with sepsis and that older catheter, we may pull it and cut off the tip and send it to the lab and see if any bacteria grow from that. And any wounds as well, would culture the wounds. And definitely imaging modalities like your chest x-rays, abdominal CT, ultrasounds, and head CAT scan to rule out any other abnormalities, even cerebral abscesses as well, that can cause sepsis. So my portion of the talk is completed. I'd like to introduce Dr. Htet here to take over the presentation.
Thank you, Dr. Srinivas. Our next presenter is Dr. Natalie Htet. Dr. Htet is an intensive care unit attending physician at Washington Hospital. Please welcome Dr. Natalie Htet.
Thank you for inviting me to this opportunity, and thank you, Washington Hospital. I hope I can teach everyone better about how sepsis is treated. My role as an intensive physician, as an intensive care physician, my role is mostly to treat a lot of patients with sepsis in the ICU, but I hope to educate you all on how sepsis gets treated generally as well as in the ICU. So there have been several effective measures that we know that help patients with sepsis. So they're a selective collection of treatments that helps patients with sepsis. It's known as bundles, and if those therapies get provided early, the patient's outcome is better. And we also know there are supportive measures that help with sepsis treatment. So a bundle means it's a group of interventions when instituted together can give better outcomes than when done individually. So there is this committee called Surviving Sepsis Campaign put together by the United States and international foundations on helping patients with sepsis. And based on their guidelines, the therapies for patients with sepsis includes IV fluids, antibiotics, oxygen, and some patients who have trouble breathing may need to be mechanically ventilated, which is also known as a life support machine. Some patients with renal failure may need dialysis. And if the source of infection can be surgically removed, they may need surgery. So fluids like that in the previous picture and antibiotics need to be initiated within 3 hours of presentation. And this is what a picture of mechanical ventilation or life support machine looks like. And what it does is it provides breathing when a patient has a hard time breathing, and this machine does the breathing for the patient. This is what a dialysis machine looks like. And dialysis machine is known as the life support for the kidney. So it's a supporting device that does the job of your kidneys, and it filters out toxin and gets rid of toxin and gives clean blood back to the patient. And you may need a surgical intervention if your source of infection is severe and needs to be surgically removed. So there are several things we still don't know about the treatment of sepsis. We don't know how exact mechanism of sepsis is. And although there are several therapies that we know that are effective, there's no silver bullet that stop everything, And although there are over 150 trials, there's no cure. We do know there is supportive care and therapies that help. Okay, there have been years of research for figuring out why an individual may be most sick with sepsis, while some other patients may not be that sick. These terms and therapies have been introduced and studied for years. Our landscape, how physicians are treating patients with sepsis, is evolving. So now we try to target patients early, and we give early goal-directed therapy. So meaning, patients need to show up and come into hospital early, and your outcome is a lot better. And we have better screening tools to identify who is going to be very sick from sepsis versus who will get a milder infection and not turn into the chance of having sepsis. So let's go over a couple of case studies to understand how a patient with sepsis may appear in the hospital. So let's talk about this patient who's an 82-year-old female. She was just having back pain, low energy, not wanting to eat, and having some chills. But she has a history of dementia, diabetes, and high blood pressure. She can't tell exactly what was going on, but she had a temperature of 101. Her heart rate, her pulse rate is pretty fast. And since she has dementia and she can't walk around much, she has a decubitus ulcer, which is what you see in the photo. So this is an example of someone who has sepsis due to the infection in the decubitus ulcer. Okay, so let's go over to another case. This is a 79-year-old man who is currently living in a skilled nursing facility. He has been altered, like he appears confused for the last 8 hours. And then last time he ate dinner, he seems normal, but starting this morning, he seems confused and not like himself. But he does have a past medical history of diabetes. He was a smoker, so he has what we know as COPD, or chronic obstructive pulmonary disease. He also has a heart attack before. But then when the nurses check his temperature, he was febrile. His temperature is 102. His heart rate is fast. His blood pressure appears to be on the low side, and his oxygen saturation is low. So this is an example of a patient who has sepsis due to a pneumonia. Let's talk about case number 3. So this is a young 38-year-old. Although she's young, she has breast cancer, and she's currently taking chemotherapy medication. So what that means is her body immune system, like her body's ability to fight infection, is not as strong as another 38-year-old patient. She has been having fever, sore throat, and body ache for the last 2 days. And the bottom picture is a picture of her throat, how it looks inside. And as you see, those swollen lesions, they are her tonsil, and the tonsils are quite red and inflamed and very angry looking. So this is a picture of tonsillitis. So she has sepsis from tonsillitis. So complications of sepsis, so when sepsis get very severe, can lead to permanent organ injury. So meaning, some patients, their kidneys fail and they need to go on dialysis, and maybe lifelong dialysis. Some patients who have lung injury, their lungs get very severe that they may need to have tracheostomy, which is a surgical incision in the neck right here to allow being able to breathe on the machine long-term, mechanical ventilation, life support machine long-term. And some patients with sepsis get deconditioned, that they are very weak. And there's also another syndrome known as post-ICU syndrome. So what post-ICU, post-intensive care syndrome stands for is a collective health problems that remain after critical illness. So, if after it affects multiple family members, it involves the body, thoughts, feelings, and mind. And we also know that patients also may develop ICU acquired weakness. So some patients on the ventilator, 50% of patients with sepsis, or even all patients who are in ICU with admissions longer than a week, they get weak. That it's hard for them to go back home. And they, even though if they were 100% functional, doing cooking, cleaning, eating, everything by themselves, after staying in ICU for longer than a week, they get weak. The patients get weak, so it's hard to go back home and do everything that they were doing before. And recovery may take over a year. And some patients have trouble remembering. They have brain dysfunction. It's hard to solve problems, even though you could be very intellectually capable of doing your own your own checks and balancing. It's hard to do all of that. So some of these brain dysfunction and ability to do your own daily activities may take a toll on how you want to live. You may need to go over to a skilled nursing facility or rehab facility after your recovery from ICU. And we also noticed that some patients have mental health issues. They have trouble with sleep, they have nightmares. Some patients have depression and anxiety. Some patients still remember vividly how their experience in the ICU was. It's very similar to how veterans remember from or like, their symptoms are very similar to post-traumatic stress disorder, and it's hard for some patients to get back to the jobs that they had before their illness. And the family is heavily impacted. The family often feels very confused and worried, not knowing how to take care of their loved one, and oftentimes they are in a position where they have to make stressful decisions for their loved one, and their families, their own mental health also gets deteriorated. So what can you do to help? I think first thing family can do is you have to take care of yourself and take time to understand your family member's illness and treatment options. Ask questions. Ask the providers what the chances are, and keep a journal. And and the team and the family works together with physicians, nurses, therapists, everyone as a team to try to improve the patient. So the team involves physical therapists, occupational therapists, speech therapists, as well as physicians, nurses, and most importantly, the family and the patient on how to help bring the patient back to their functional status that they desire. And sometimes we may need to get palliative care involved. Palliative care is a group of physicians or nurses and nurse practitioners who help patients in a situation when their medical illnesses are too much to take care of. And then, it's time to start focusing on how making sure that their goals and their wishes are met, rather than talking about numbers, medications. Maybe it's time to talk about whether medicine overall is doing a good job for taking care of a patient, how else we can do to help care for a patient. And a part of palliative care means we also want to honor the patient's wishes. So discussions about whether a patient needs to go to a nursing home or a rehab facility, that comes into play. And oftentimes family should have these discussions with their loved one ahead of time. Decisions such as life support, dialysis, breathing machine. These are really difficult topics if you ever are in a situation to discuss about those. So it's really important to discuss these issues ahead of time. Tell your family what your wishes are if you're ever in a dire situation that, discuss that you need to be put on a life support machine, or you need to be put on like dialysis machine. It's time to start discussing those ahead of time. And another major thing is prevention. If we can prevent sepsis from happening, that would be great. So the first step, it starts off with hand washing. So wash your hands very well. We carry germs in our hands all the time. And get vaccinated. Flu shot is great. And get pneumococcal vaccination if you're over 65 or if you're over 60 with comorbid conditions. And please get the COVID vaccine. And COVID vaccine is great to help reduce your chance of having severe COVID illness from COVID virus. And we know that vaccination prevents communicable diseases. This is the world map of measles, all of the outbreaks that happen over time. So, if you look at measles, rubella, polio, whooping cough, these are several illnesses that medicine and vaccinations help prevent. Okay. Cover your cough, wear a mask, and stay healthy, take care of yourself, exercise, and eat well. And thank you very much for this opportunity, and I hope you all take care of yourself. And I'd like to thank our sepsis committee members who started this sepsis program at Washington Hospital. And our goal from the hospital is to build awareness of sepsis through education. If you're ill, come over to the hospital. We will screen you. We'll make sure that you are doing well, and we'll use evidence-based guideline in clinical practice to make sure that your care is exactly as it should be. And we try to save lives through better sepsis care. Thank you.
Okay, we'll start the question and answer session. Dr. Srinivas, is sepsis contagious?
Sepsis in and of itself is not contagious. Some of the infections that can lead to sepsis, particularly respiratory infections, are contagious or can be contagious, as well as certain other infections like C. diff that would require contact precautions, and certain kinds of drug-resistant urinary tract infections, etc. So sepsis in and of itself is not contagious, but some of the illnesses, or the infections, I should say, that can lead to the syndrome of sepsis are.
And to add to that question, do most people acquire sepsis in the hospital, or are they admitted with it?
Most patients have sepsis develop outside in the community, and the vast majority of sepsis cases are discovered in the ER on arrival to the ER, and then the remainder, about 30% of those cases, are discovered after they're in the hospital already, or they develop it while they're in hospital.
Okay. Dr. Htet, how quickly does sepsis set in?
Sepsis can set in fairly quickly, within hours or up to days. It depends on the patient's immune system. So say if a person has cancer, on chemotherapy, or is on immunosuppressive medications, so their immune system may not be quite strong. In that case, sepsis can develop within hours of having an infection.
Okay, our last question, Dr. Srinivas. The symptoms for sepsis and COVID-19 are very similar. How can one know the difference, and how can I protect myself and my family when seeking treatment?
So prevention is important. I think you're going to do a lot of similar preventive techniques for both. Mask wearing, of course, is very important. It's showed to decrease the risk of transmission of respiratory illness, as well as COVID. And hand washing is number one on the list of prevention for against infectious diseases. So I would say those couple of things are important. Vaccinations that we both touched on earlier, very important to get vaccinated if you can, if it's available to you, and if you qualify for, say, the pneumococcal vaccine, and of course the yearly flu vaccine. So I would say those are the ways that you can prevent it. In terms of overlap, respiratory infections that can cause sepsis do overlap in terms of symptoms with patients that present with COVID, but we're starting to see more patients that are presenting atypically with COVID that, say, don't have loss of taste and smell and don't have a cough or fever at home, and it might be lower on our list of differential, but we still see that they have COVID. So it's hard to say. I think some cases they overlap, but we're starting to see more that don't overlap.
Okay, one additional question, I apologize. Is weight loss a symptom to sepsis?
Unintentional weight loss can be a finding seen in cancer, and it certainly can be seen in sepsis too, for sure, because if you're not feeling well, it really depends on for how long we're talking. But yes, if you're not eating, drinking, exercising, and doing kind of your normal routine, even if you're not really exercising vigorously, if you're just getting up and going to the bathroom and going around the block for a walk, etc., you're getting your blood flowing and your muscles working, you can definitely get muscle wasting if you notice you're sitting at home and you're not as active as usual and you're not taking in as much fluids and food, kind of like what happens when patients are sick and they're admitted to the hospital with sepsis, and there's muscle wasting in those patients and significant weight loss. So yes, it is a concerning symptom, or sign, actually.
Thank you. This concludes our program. Thank you, Dr. Srinivas and Dr. Htet, for your expertise, and thank you to our viewers for tuning in. The entire broadcast of this afternoon's event will be available on Facebook and YouTube.